Basically, Taghreed Adam and myself want to make three key points in our presentation. We want to start by talking about some of the cognitive and operational biases that are really apparent that many have observed over the years in development in general, but in global public health in particular. And there are many analysts and practitioners that have identified these biases. We want to present these biases as part of the rationale for why complex systems thinking is really important for what we do. Second, we want to go on to argue that many of the problems that we face in public health and in health system strengthening in particular can be better understood and navigated using tools, concepts, ideas and mindsets from the broad field of complex adaptive systems research. And third and finally, we want to show that these tools and these principles and these ideas have considerable and increasingly practical relevance for the work that we do in global health and health systems in particular. So let me begin, there's the agenda. Let me begin by sharing two contrasting stories that I'm sure both you'll all know very well. The first being the campaign to eradicate smallpox and the second being the campaign to eradicate malaria that was started in the 1960s. Now, smallpox eradication has been rightly described as one of the greatest achievements in global public health. That's one of the greatest achievements of human beings anytime, anywhere. And it's the only human disease ever to be eradicated. It was joined a few years ago by rinderpest, which is a cattle disease, which was also eradicated. And now, for those of you, and this is the general incidence levels where you can see from considerable levels of spikes in the 1950s, the smallpox program was announced in 1959. It got a strong US involvement from 1965 onwards. 1967 was when eradication was actually announced, and only 14 years later it was gone from the face of the planet. Now, as those of you who are at Johns Hopkins will know well, at the start of the smallpox eradication campaign, it was envisaged in working in very specific ways, in very top-down, straightforward ways. It was kind of conceived of as a gleaming, well-oiled machine that would go from one country to another, applying exactly the same kind of formula of activities and actions, reaching the magic number, which is 80% vaccination rates, which are the levels that led to eradication in developed countries. And by doing that, the program would essentially help to eradicate smallpox around the world. However, in reality, and actually it's worth saying that for many people, that's still the perception of how the smallpox program actually worked. The reality, though, was that the smallpox program, the mass vaccination, wasn't the only or even the most important part of the strategy. The really innovative, experimental, bottom-up elements of the strategy around surveillance and containment that were far more important than vaccination, and they helped break the transmission chain of smallpox, even in those countries where the vaccination rates were less than 50%. And so this successful strategy that was originally designed as this process of top-down planning, a highly visible approach to vaccination, was a process of emergent, adaptive, networked experimentation. Each country had to develop its own country-specific approaches, and the whole campaign had to adapt and learn and adjust according to context. And this is one quote from Don Henderson, who was the much lauded director of the campaign and indeed former dean and still emeritus dean here at Johns Hopkins. This process of learning has been described as the single most important element of the success of the campaign. And I just want you to kind of hold that in your mind as I move on to talk about the malaria campaign of the same period. Now, in 1969, the Pearson Commission, led by Lester Pearson, from which we have the 0.7% target for global, for development aid of developed countries' GDP, they confidently pronounced that the disease was virtually eliminated in 1969. So, which begs the question, given the kind of overall data since then, from around pretty much from the announcement onwards, what went wrong? There's a recent editorial in The Lancet which described the eradication campaign as far too monodimensional. It relied far too much on single silver bullets, in this case DDT, or insecticide spraying. And it neglected the palpable problem that the delivery infrastructure was simply not in place in many parts of the malarious world. And so the emergence of widespread mosquito resistance to DDT and parasite resistance to the cheap mainstay of therapies more recently has compounded this problem. Now, this is a description of the malaria campaign by Don Henderson. And I'm just going to read out the bit in red in the middle. It mandated identical job descriptions in every country and prescribed specific charts to be displayed on each office wall at each administrative level. The programme was conceived and executed as a military operation to be conducted in an identical manner, whatever the battlefield. Now, the assumption was that the formula for eradication was known, it was clear, it was unambiguous, and all the international systems and national health actors needed to do was follow that formula. And so much was this kind of belief in the formula held that the senior leaders and programme managers banned research from the programme, said we didn't need research in order to make this effective. And the narrowness of the malaria response allowed the mosquito to become resistant. More recently, has allowed the parasite to become resistant to ART therapy. And so I would argue that this silver bullet problem has also proved quite resilient. The clinical microbiologists Richard Carter and Kamini Mendis essentially critique this and say exactly the same tools and mindsets are being used in the rollback malaria campaign today as were being used in the 1960s in the malaria eradication programme, which obviously leaves us open to the same risks, and many of which are now becoming apparent. Now there's a few nuanced things that are probably useful here. Malaria is a much more complex and adaptive pathogenic foe than smallpox. But if anything, that means we should have been more adaptive with the malaria response, not less. But we weren't, and the implications are very clear. And we've actually got more tools against malaria today. So we've got, for example, something like 10 to 12 different insecticides that we can use. So there is a bit more diversity, but overall, the mindset of the 1960s campaign hasn't changed. And I would argue, and I'd be interested to see a show of hands, which of these models does the audience think has had more of an influence on public health today? The successful smallpox model or the unsuccessful malaria model? Show of hands. Who thinks smallpox? Who thinks malaria? Okay, I mean that in itself is quite interesting. I think that I would argue that there's a basic problem, a basic issue in the way that we think about these. That the malaria model, the failed model, has ended up becoming perhaps not all of its most excessive elements, but the core principles of the malaria model have become much more influential in the way that we think about and do global health efforts. And Henderson and the smallpox team deliberately set out not to emulate the malaria model for exactly this reason. And one of the advantages they had was that the smallpox programme was much smaller, and therefore they could escape the watchful eyes of those senior leaders that essentially wanted to engineer it and turn it into a top-down process. As Don Henderson later famously put it, the only way he was able to manage the process of eradicating smallpox was to break every rule in the WHO book. Now, I think this malaria model, this idea that you can roll out standard best practices regardless of context of complexity, has become really prominent across development as a whole. And I think that it's indicative of kind of mindset, a set of assumptions about what we do in aid and what we do think about in aid and how we think about aid problems, which I don't think any of us individually believe, but actually we act as if this is the way the world works. And if I was to summarise it, we often seem to act and think as if populations, health problems, diseases, economies, societies, ecologies, etc., are essentially analogous to one gigantic clockwork, a series or a car engine. So we act as if we can analyse and precisely predict and manage the behaviour of these systems that we're working in by essentially reducing down to just the thing we're most interested in and ignoring everything else. And that's exactly what the malaria campaign did. And the idea behind policy and practice in this wonderful clockwork Newtonian world is to engineer and construct change through reductionist analysis, through finding the single best solutions, through prediction, planning and control. And these kinds of assumptions, this kind of neo-Newtonian model, underpins large amounts of what the formal development system tries to do, whether it's community development efforts or long-term statewide reconstruction, or indeed large-scale global health programs. And this comes with a number of biases, a number of implicit assumptions that when you add them all up, amount to institutions doing things in ways which simply do not correlate to reality. So the first set of biases is around systems, that the systems we are working in and working with are closed, ordered, reducible to just the bits that we're interested in, that we somehow stand outside of the system and can fiddle with it to our kind of interest and hold everything else constant. And these systems are nothing more than the sum of their parts. So all we have to do as external development agencies or health agencies is change the parts and we can change the system. Thinking about relationships, that we largely think about the relationships between individuals, between entities, between structures in developing countries as if they were non-existent, or even worse, as if the most important relationship is the one with the external actor. And so these relationships can be rewritten. And as a result, we assume that a lot of the most important characteristics of these individuals or these groups are to be found at that individual level, that the context and the history and the dynamics between them can be effectively ignored. We tend to think about humans as being uber rational, that humans make decisions based on rational self-interest, and that behaviours can be specified in top-down ways, and that by simply changing the elements of this elaborate calculus that we all have going on in our heads, we can change behaviour. And finally, change. That change is linear and additive and proportional, that if you do X and it leads to Y, then doing more of X must always lead to more of Y. It's a world of lovely straight line graphs and XY relationships. Now, these ideas aren't useless. They have their origins in 19th century physical sciences, and they found their ways into organisations and institutions through scientific management and the ideas of ideal bureaucracy of that same period, and neoclassical economics. So these are the kinds of ideas that Henry Ford used to deliver any colour car as long as it's black. So perhaps unsurprisingly, they're most useful, they work brilliantly in situations where machines work well. They come into their own, where there's a straightforward task to perform, an identical, stable context and operating environment, identical duplicable products, and compliant, predictable, reliant parts, including the human components. Now, hands up who thinks their working environment resembles this, let alone problems of global health in developing countries. Although it seems risible, these are exactly the assumptions that underpin big aid, failed malaria approaches, the attempts to engineer change through the Millennium Development Goals and the related campaigns. Jeff Sachs famously critiqued Millennium Villages campaign. And I think there's a problem with this, because everyone within the system is talking about this kind of outmoded business model of how we think about the way change happens. And increasingly, this set of assumptions, I would say, argue, is actually a big part of that outmoded system. I'm not saying, I have to reiterate, that any one of us believes these things, or any individual has this kind of, or any organisation puts this into their strategy and says this is the way that we think change is going to happen. It's more that this way of thinking is hardwired into institutions, they're hardwired into incentives. I think there are lots of people in public health and in development more generally who do work in remarkably creative and innovative ways, but they do this despite the system rather than because of it. And I think the smallpox and malaria contrast really show how the kind of dysfunctionality of this problem, where the real adaptive success have been less influential than the massive top-down failure. And I think the reason this is so important is if we continue with our addiction to reductionism, we risk not at all learning from our successes and not at all understanding our failures. Now, it's worth asking why, given every generation, dating all the way back to the 1940s, every generation of global health analysts and development analysts have come up with some version of this problem, why has it refused to die? And I think it may be because, in part, and this is what I want to go on to argue, is that there are some problems where this kind of neo-Newtonian approach is exactly what's needed, and where exactly this kind of thinking is what is relevant. But I think a more fundamental problem is that it may well be better for individual and institutional reputation to fail conventionally within the confines of this paradigm than to move beyond it and succeed unconventionally. So let me move on to the second part of our argument. So the obvious reality is development and humanitarian problems, the world at large, are not like Newtonian clockworks, they're not like Ford motor cars. And growing numbers of experts have been pointing to the ideas of complex adaptive systems as an alternative theoretical model for development. And this is an area that I explore at some length in a book I've just written on this topic. And because I know that some of you will have engaged with these ideas, but not everyone will have engaged with these ideas, I thought it'd be useful to actually just share a little bit of intellectual history of where these ideas came from, because it can help us understand why they're important for science more generally, and why they're particularly important for us in public health and health systems work. So that the seeds of what then were the new complexity movement, and actually people today talk about the new movement of complex adaptive systems, they were sown at least 65 years ago by Warren Weaver, who was the science vice president of the Rockefeller Foundation. And he's a forgotten giant of 20th century research. He was decorated by America, Canada, France and Britain for his work during the war. He led work on microbiology, on cancer research, on agricultural research. He personally mentored almost 20 future Nobel laureates. I think that part of the reason he isn't particularly well known was he was a very humble man without much ego, which says something about our society, I think. But essentially, in 1948, he found himself in a position not dissimilar to many modern donors, many modern research institutes, trying to think through the kinds of problems his foundation should be trying to address. And as I explain in my book, he was a true polymath, and he was well placed to do so. And what he observed was a significant gap in the scientific and research activities of the foundation and in the global scientific community as a whole. He argued that there were three kinds of problems in science, and that there had been more progress on two than on the third. The first set of problems are problems of organised simplicity. So these are problems which essentially can be boiled down to one or two variables, and where it always works in the same way regardless of the settings. So Newtonian mechanics being a classic example, but not just Newtonian mechanics. This kind of principles underpins many of the advances of the industrial age. So transportation, basic health provision, germ theory, a lot of this stuff is based on exactly this kind of thinking. What he argued was, having kind of cracked those kinds of problems, somewhere around the end of the 19th century, early 20th century, science leapt to the other extreme and started looking at problems of disorganised complexity. These are problems with many variables, all of which were interacting randomly. So the motion of atoms, thermodynamics, statistical mechanics, population studies, as was done at that point, actuarial studies, the kinds of tools that insurance agencies used to apply to risks and turn a profit. And the value of these problems is that you can't actually apply statistically, you can't apply the kind of Newtonian mechanics, but you can apply statistics to identify average behaviours. And because they are random problems, average behaviours actually give us a useful insight into the way these problems actually work. Now, what he identified was this kind of big gap in the middle, which were problems of organised complexity. And these are problems which didn't have huge numbers of variables, nor were they one or two. There were sizable numbers of variables which are interrelated into an organic whole, where you can't boil things down to one or two variables. You can't usefully apply statistics and identify averages. And there were things like commodity prices, economic development, child growth, the growth of cities, educational outcomes, mass social movements, the spread of diseases. And he lists these out in this 6-page paper. And essentially what he argued was that science needed to put much more effort into this third class of problems. He said that all of the problems that we're going to face in the latter half of the 20th century were of this third kind, but actually very little scientific funding was going into this kind of work. And so he called for what he described as a third great advance, which would combine multidisciplinary working with the power of what he rather touchingly described as advanced counting machines, essentially computers. And indeed, he actually wrote one of the key texts in information theory in the 1950s. Now, he's had considerable influence. He was cited across the intellectual spectrum. He was cited by 2 Nobel laureates in their acceptance speeches. Jane Jacobs, who one of the perhaps the most influential scholar on urban issues, cited him extensively in her famous book, The Death on Urban Thinking. And he helped trigger the field of systems thinking. And time that I spent at the Santa Fe Institute, and I spoke to a number of the founders there, and the ideas behind Warren Weaver's work, published in 1948, many described as saying the reason why the Santa Fe Institute took about 30 to 40 years to be set up in 1984 was that computers hadn't got to the point where they were powerful enough or small enough to actually enable an institute of researchers to come together and work on these problems together. So at 6 pages long, it may well be the shortest piece of work ever to have inspired a new movement in scientific thinking. Now, many argue that we work in a world dominated by complex adaptive systems with exactly the characteristics that Warren Weaver described. So they're complex in that they have many interacting agents and organizations of agents. They're adaptive in that they design strategies and they evolve over time. And they're systems in that macro patterns emerge from micro behavior. So ecological systems are complex, and treating them as simple machines has costs which are increasingly all around us. Climate is clearly complex and non-linear. The economy is complex at national and global levels. Energy is complex. Food systems, information systems, our own organizations. All of these can be usefully described as complex adaptive systems. Now, when I got interested in this, I actually went and spent some time at the Santa Fe Institute in New Mexico, which I know Josh is one of the kind of luminaries of, and we'll be hearing from him tomorrow. And I spent a bit of time talking to the researchers there who were doing work on social complexity in particular. And I identified that there are 4 broad approaches which are really relevant. And I'm going to, these are kind of, if you like, broad schools of approaches within which there are many, many different tools, but they all help us engage with complexity of the kind that Warren Weaver was interested in. So these tools are tools which, first of all, help us think about systems that are not reducible to 1 or 2 variables, where we can take a wide-angled, coarse-grained view of the problems that we face and understand how they're shaped by feedback and interdependence. To think about networks not as if individuals are atomized, nor as if they had exactly the same relationship with everyone, but actually that there's an underlying structure of social, economic and political relationships, and these change over time and have a profound influence on everything from economic attainment through to social standing. To think more precisely about behaviours, about how we individually think and make decisions, and how our individual decisions aggregate up to an overall system-wide performance. And about the dynamics of change, about change being non-linear, characterised by surprise and tipping points and by power laws, where actually this idea of kind of straight line charts of kind of XY relationships that continue endlessly into the future is completely flawed. So together, and I just want to present this as a contrast, that it presents quite a comprehensive alternative to the standard operating assumptions of aid I described earlier. So these are the kind of tools of complex adaptive systems, and these are the kind of assumptions that underpin the malaria campaign. So part of the reason, I'm not saying that the smallpox campaign used these tools, but part of the value of these tools is that they can provide a comprehensive alternative to the assumptions that underpin a lot of what we do in global health. Now, I've identified a number of different case studies which I go into in depth in the book around how people have used these ideas and these tools to understand development and health problems and change the way that they deal with them as a result. But what I'm going to do now is to hand over to Taghreed, who's going to talk about some very specific case studies in the context of global public health and health systems development.
Thanks, Ben. So my objective for this half is to bring you back from this very nice overview to practically what does it mean to us if we want to answer health systems questions related to the different situations we are in different countries. So some of you have seen this book. It's System Thinking for Health System Strengthening, where we argue that the very helpful 6 building blocks of the health system that WHO have been putting forward in 2007, they are helpful in the sense that they are explaining to us how do we think about health systems. They describe the 6 building blocks, but what we are trying to emphasize is that it's really important to go beyond that. So often we try to understand health system issues and try to say, okay, what it means for the human resource component or the financing component, etc. But it's really important to really push beyond that and think of the interactions and the relationships and how they're linked to each other, how intervening in one of them create feedback loops that really change the course of events, how people are very important and affect the system, whether it's people as human resource or people as beneficiaries of the health system, and how often when we design policies, we focus on the supply side of things and really don't talk about the demand side of things when we design policies even, and how much it's important to the design, let alone how the policy will be implemented. So how do we perfection or improve the health system with this in mind is really what we are concerned about in this discussion and the workshop, I hope. And to guide this discussion a little bit so that you can have a little bit of thinking how, for what should we really go into that complexity? Is everything requiring some complex adaptive system thinking approach? While we think that every intervention almost have system-wide effects, we think that it's a helpful way to think about it like this. The more the system-wide effects you expect for intervention on this axis, and the more complex you think the intervention is, the more you need a system thinking approach. So you can think of these parts, for example, in the beginning here, the change in microscopy guidelines is not that complicated, although it has system-wide effects, but maybe with some training and change in the guidelines it can happen. While if we deal with things about social health insurance, pay for performance, and all these even increase health worker salaries, so things already start to be complex. So that's just to give you an idea of how there is, with increasing complexity, you may want more of that, but obviously it applies to every policy or way of intervening in the system. The other thing, before I give you some concrete examples of how different researchers use these approaches in answering their problems, I thought this table is helpful. It helped me personally to understand what is it that system thinking adds compared to our usual approach. I'm saying usual because I don't want to call it traditional or conventional or something else, but basically this usual approach represents really how many of us were taught. I'm a physician, nurses, even epidemiologists, pharmacists, we were all taught to to reduce things into pieces, and when we understand the pieces very well, we think we solve the problem. So we really tend to understand the details where it's important, and this we call focus on events, try to understand them, while system thinking requires thinking of the dynamics of the patterns, the pattern of behavior that was created by a certain intervention and what this behavior led to, rather than thinking of the system as an effect. Sometimes, for example, in econometrics and regression analysis, we tend to even control for them, trying to eliminate them and see what are the impact of the intervention. System thinking thinks more of the behavior as internal to the system, internal to what you've done, which generates certain behavior through the rules and the rules of the system and the actors of the system. So trying to understand the system as a cause of what's happening, rather than trying to think of it as an effect that you need to control for. The third one that is quite useful is to what I was saying earlier, this understanding the detail, thinking of one element after one element. So even if I take the example of the health system building block, trying to understand financing separately from human resource, etc., while forest thinking really try to take a step back, look at the big picture, look at the context, the relationships, what is really governing the whole reaction and effects that the intervention that is implementing is doing. Factors thinking compared to operational thinking, rather than thinking of the factors as influencing or correlating, thinking more of them as the cause, and thinking of causality and the behavior as generated through that. And obviously the linear thinking versus, which is effects going in one direction, compared to the loop thinking and feedback loops that are generating new effects and so on, constant change as we call it as well. So before I go to some examples, I just wanted to give this slide because very often I get asked this question when I present similar presentations, when they say, we are with you, that sounds really good, but how can one use system thinking and complexity science in practice? And these are just 4 examples of the many ways we can really apply this thinking to. One can use it to understand a health system problem, why health workers are not motivated, or how can we increase the demand for something, vouchers, for example, or vaccination, etc. Or in designing or redesigning an intervention. We know an intervention is not working, and we can think how can one use the system thinking approaches, including the characteristics of complex systems, to design or to improve the design of interventions. The other one is to conceptualize and conduct evaluations that are appropriate for health systems and their complexity, because so often we see evaluations of complex interventions done really, really simplistically. And when we have in mind the complexity of health systems, we can better design evaluations that answer the real questions. And last but not least, trying to capture new phenomena or theories, understand how health workers behave or how the demand get initiated, etc. And this itself can enrich our learning to design interventions in the future in a more system-respecting way. So now I have 3 case studies. Many of these case studies have authors in the audience, and this one has David Bishayu and David Peters as well. This paper is really a nice paper. It was one of the papers that I learned a lot from. It talks about how the essential drug policy was implemented in 3 counties in China using a complex adaptive systems lens. And it was, through the paper, it tried to look at how the system adapted to this policy by changing the rules and the relationships between the different actors, creating some unanticipated outcomes, and also some coping mechanisms. I'm not going in this example to go through a lot because I gave you the reference, but there are really papers that are worth looking at and learning from. Very briefly, you can see that the design of this policy is very neat and linear. You know, you have the central government and the provincial government and the city. This first 3 are mainly the regulatory governance aspects of the policy, and then you have the drug producers and drug distributors as the providers of the medicine. You have the hospital with the health service delivery, and you have the health insurance doing the payment. So it's all very expected, to flow as designed. While a stakeholder analysis of what actually happened in the different 3 counties showed that it's much more complex than this. I'm not going to go through the details, but you can also see that the design itself ignored some other actors that are quite key and were not really involved in the design, but they of course are there. They acted and adapted to the policy, which of course had a lot of feedback into the system and how the different the behavior changed in terms of coping mechanisms from the health providers, etc. There is a very nice table in this paper that talks about the main objective of the health, the actors, and the role in the policy, and how did they change in response to the policy itself. So it's quite nice, but it shows a lot of these aspects of complex adaptive systems, the divergent and unpredicted outcomes, the adaptive and self-organizational behaviors, etc. The second paper I wanted to present is by Agnes Rouachana here with us and colleagues. It's a paper that uses system dynamic approaches to understand the immunization and the coverage of immunization in Uganda. So I'm only having 2 slides here. It's also a very instructive paper using causal loop diagrams, which you will be introduced to later today. The research design of this paper is the research synthesis methodology, and I really find this approach very helpful, and I hope you will try to look at it because it can be really relevant to many of you. It lends itself to many studies, and it's quite logic in the way you think and want to collect data to answer many problems. So you would start with a problem statement where you'll have preliminary interviews, collect some data to understand the mission and the vision, the goal of the policy, identify the key stakeholders, and identify the problems. This is stage 1. Once this is clear, with some field studies, you'll have a better idea because you now have a better picture of what are the problems, and through this, you start develop a better understanding, which leads to drawing some causal loop diagrams or influence loop diagrams that explain the questions, the problems, the related factors, the feedback loops, etc. Once you are in this stage 3, this is a good time to involve policymakers, where you could have workshops to try and validate your causal loop diagrams, try to see, okay, is this what correspond with what you know? Do you think these relationships are okay, etc.? And once this happens, you get to this phase where you can empirically test some scenarios to try and address some of the problems, for example. So you'd populate the dynamic model with data, and you can then start, this is then the system dynamic model phase. So if you think about it, you can think of the first three phases as the qualitative aspect of your work, and then it starts to become system dynamic modeling. The quantitative aspect can start from here, while you can then go back to talk to policymakers again in stage 5 and 6 to show them the outcome of these simulations and discuss with them what could be relevant policy options for them. So this is one of two loops in this paper. This is the demand side causal loop diagrams of the demand for immunization. And as you see, in the middle, this is the demand for immunization that is explained by many aspects. You see that in bold are the main aspects, which is the level of immunization awareness, mothers' availability, and the level of trust in the system. These ones together, this is all collected from different types of data, qualitative and quantitative interviews, but they all together helped clarifying a picture, which is what is actually making the demand increase. This is your question of interest. And you can see that things that like belief in myth or household issues, etc., come from these sort of qualitative aspects and are very helpful to explain. You can do a lot with causal loop diagram. You can not only explain, you can also identify the strength or the importance of one aspect versus the other. Because then when you start discussing with policymakers, you can also guide them into what seemed important that merit some action, and what could be good value for money in terms of acting. So again, I'm not going to go through all of this, but later today you'll be introduced to how to read these loops, what are the balancing and reinforcing loops, what are feedback loops, how can you construct them or not. But this is just something that shows you one way of presenting information that comes from considering and working with complexity. My third example is by Malik et al. No authors are here in this room, except that this is one of about 14 papers that were submitted to a peer-reviewed supplement on system thinking that the Alliance is coordinating and will be published and launched in September. But the first 3 papers are already going to be published today. One of them is by David Bichat and Ligia, and hopefully the others, at least 7 papers, will be available in about a week or so you can have a look at them. And this is one of them that will be published soon, and it's using stakeholder analysis and social network analysis to understand the advice-seeking behavior among primary health care, and taking 2 examples, TB and malaria, trying to understand what do physicians do to seek advice when they have complicated cases, and how does it work for them. So just one slide, just to show you that the first is what the system thought should happen. And that's, of course, the efficient, more logic way. You have the hospital in the middle, you have the big centers, the blue dots, and then you have the peripheral health units. So everyone, of course, seek advice in this manner. But actually what happened, I don't know if you can see very well from the lower slide, through the social graphs that they drew, it's clear that the peripheral unit sometimes just bypass the health center and go directly to the hospital. Sometimes they seek advice outside the district altogether or to private sectors. The conclusion from this paper was that 3 things led to this sort of behavior by the health workers. One is their own perception of the skills, the clinical skills of their supervisors, because they did not believe that when they seek advice in a hierarchical way, they will get the best advice. They avoided it. The second one is the emphasis in a hierarchical way on performance rather than clinical skills or clinical guidance, in the sense that all what they care about, we want to show that TB is well maintained, we don't have complicated cases, etc. So whenever there was questions about complicated TB cases, the intention was to bury it, refer it, we don't want to hear about it, rather than trying to see how can one do it in practice. And the third one is no establishment of good referral system did not lead them to really, what is the point of asking the health center and then the hospital when the referral system doesn't work? So they just bypass it altogether. So all what I'm saying here, that these are all examples to give you an idea of what can one do using the different approaches and tools to understand the reality, because very often when we read publications, we learn something, but it's so superficial that doesn't advance us so much. But what we need is to understand something that is helpful, something that can lead to actual design change that is actually going to make a difference, because we understand why and how the system reacts. So I'm going to have my closing slide, and then Ben will come again. These are just one closing thoughts from my side, and Ben will have his. And three key messages I wanted to leave with this presentation. The first is, I'm sure you will agree with me that so many of the contemporary interventions and policies are a bit simplistic in the way they are designed, and they really need to be reconceptualized using a CAS lens, because otherwise any simple approach just doesn't work, and even if it worked for half a year or a year, that's really it. The second is that there are tools and methods, most probably more in other disciplines than health, that are used very well in other disciplines like engineering and management and business, but we need to exploit them a bit more in health. But to me, I'm someone who got introduced to this in 2008. I'm very interested and excited about it, but I have a lot to learn. Everyone can do it, and some people do and apply these thinking and concepts, be it researchers or policymakers. They don't call it CAS or system thinking, but we all do it one way or the other. We need to just go beyond terminology and try to really innovate and have a little bit more courage in going into new fields that is not exploited enough in health. And we will have struggle with reviewers. I did, many of you did. They are not used to this, but we just need to persevere a bit. And the third is that there is a lot of ongoing work. I told you about a supplement that will be published. There was an earlier one that also the Alliance supported in 2012, but there was also, so 4 altogether supplements on system thinking and health available since 2006. A lot of interest in this area. But I just wanted also to let you know that the Alliance, where I'm working, is also planning to launch another primary call for primary research on system thinking that is forward-looking. So keep an eye, because what we want to do is to, now that we understand a lot about how problems can be understood, we want to move this to what can you do then. So what we will be looking for is research that try to redesign, design, look at implementation issues and redefine them and so on. And this will be an opportunity that, of course, we will share with you, and hopefully between now and then you can think of what can you do to advance this field a little bit. So this is all from my side. I'll let Ben finish that.
So yeah, I guess I just wanted to add to that really. Closing messages for me, to challenge assumptions. The key to the successful case studies that I've looked at, that Taghreed presented, essentially how their proponents used ideas and approaches to challenge some long-held assumptions and ideas within public health. So the vaccine dynamics, for example, which moved away from seeing the problem as closed and static and actually trying to understand it as an open, dynamic problem. The TB treatment that essentially assumed that you could treat the networks of relationships as if they were just one big hierarchically organized system, whereas actually it's much more path dependent and historical. And the drug policy case in China, which kind of combines a lot of all of these approaches. Now, this is really about the value added of these approaches. And what I'm presenting here is, if you like, the kind of assumptions of global health that we have to contend or fight or battle with on the top row, and some of the ideas or concepts of the which underpin those systems, which the science of complex adaptive systems tries to uncover. Now, whether we see these ideas as a challenge or an opportunity is up to us. But I think it's important to say that this way of thinking isn't the only way of addressing these problems. And there are many anthropologists and social scientists that wouldn't ever talk about complex adaptive systems, that would talk about find ways of describing dynamic, path-dependent, context-specific behaviours and so on. But the value of complex adaptive systems, it enables us to challenge all of these existing biases simultaneously. So it has the potential to help us improve our ways of thinking and working in global health and move towards a way of operating that has much more fidelity to the real world. And I think it's really important to say, as Taghreed did, that not all problems, her chart that she showed, not all problems need complex adaptive systems approaches. There are some where actually a very reductionist approach is exactly what you need. But I think the key is we have to take a more scientific approach to how we do this stuff. So where the simple models are useful, we apply them as well as we can. But where they fall down, we have to be willing to explore new methods, new tools, new approaches, and to do so critically. And there's a lovely quote from Lynn Ostrom, who was on the Santa Fe Science Board for many years, won a Nobel Prize, and this is from a Nobel Prize acceptance speech. And I think it's a nice message for us over the next few days, that we should continue to use simple models where they capture enough of the core underlying structures of the problems we face, so that they usefully predict outcomes. But when the world we're trying to explain and improve is not well described by a simple model, we must continue to work to improve our frameworks and theories so as to be able to understand complexity and not simply reject it. And I think that's the message, if nothing else, that's the message that you should be carrying forward over the next few days. And hopefully there'll be some really practical examples of how we can do exactly that. Thank you.